Okay, welcome to the next question discussion. This is an infectious disease question, but again a question which I have taken from the MRCP exam question paper. It seems a very interesting question, trying to test out a couple of things as far as our understanding is concerned, and trying to maybe take our understanding to a new level. Because I think all of you would have seen this patient and seen this case. So diagnosis is not the question here; it's about what you're going to do. So 42-year-old manual laborer admitted with jaundice, tiredness, and relentless fever for 1 week. So this is a case of new onset fever. Yes, this is a case of new onset fever, which is inside a week. Okay, new onset fever inside a week. So when a patient gets admitted for a new onset fever inside a week from our tropical setting, we will have lepto, we will have dengue, we will have typhoid, we will have malaria, and scrub typhus. These are the 5 things that will actually come to our mind generally if you don't have any suspected cause or any foci like lungs or urinary tract like that. So you think of these things. Headache and myalgia were very severe, and the patient had jaundice also. So headache and myalgia being very severe and the patient having jaundice also means that dengue, typhoid, malaria are generally not that common to get associated with jaundice. So I'm not keeping them out, but okay, at least right now I think of these 2. He appeared sick and drowsy, though oriented. So the patient has become drowsy inside a week. He is febrile, tachypneic, and BP was only 160. So BP is 160, jaundice is plus. So all these things can be possible, but at this point you think of these 2. And so something catchy on examination, and this photo has been given. And now with that, the diagnosis becomes very, very clear. A very, very important message also that you please search out for, because SR may be in the axilla, SR may be in the groin, SR may be anywhere. So please search out for this. And once you see the SR, then of course you know that this is scrub. Correct, scrub types. So Aurantia, Sutsugamushi scrub type. So you know this. Now the problem is the question has been framed in such a way that they have asked for the next most important step that you have to take in this patient. Okay, so next most important step that you have to be taking in this patient is the question, and I have deliberately taken out the option. So what would you think is the next most important step if you see in this Escher? What is the next most important step? I would feel that there are 2 very important steps here, but what do you feel is the most important step? So many people, some people actually did not have any idea about scrub typhus because they've not treated any patient, they have not seen any patient proper. So they probably thought of doing this scrub IgM ELISA. Scrub IgM ELISA and all you may do, may not do, has no significance here, because scrub IgM ELISA may take more than 7 days to become positive. So at this point, if you do even get it negative, later on it becomes positive, it will take its own sweet time to give the result, and you are not going to do any bloody hell by actually taking that result out. So doing scrub IgM ELISA, of course, out of question. Then some people were actually diligent and they said that without wasting time, we have to start treating the patient. That's of course there. We have to treat the patient. He's not going good. He's actually appearing sick. He's appearing drowsy. We may lose the patient. Okay, there's always a chance like that. So what is the most cardinal part of our treatment? The most cardinal part of our treatment, many people think, is to just administer this patient doxycycline, because doxycycline is like the drug of choice in scrub, and you basically can give doxycycline and the patient will come out thumbs up. That is actually wrong. Okay, doxycycline definitely works, that has to be started, but more important than that, what they are testing out is what would you do if you see a patient like this. Obviously you will admit this patient in the ICU, there is no question about it. You will do the battery of investigations including CBC, LFT and ARP, because scrub is notoriously associated with AKI, which is a tubulointerstitial kind of AKI. So you know that that is possible, and patient's output has not been measured, so you will put a catheter. Those things are there. Most important thing is we have to manage fluids in these patients. That is where I think we have to show our diligence. So although we start this patient on doxy, some people start the patient on ceftriaxone, that's all fine, and scrub will respond to doxy, there's no question, but hemodynamically we have to lift this patient. Otherwise what will happen is by the time doxy is actually working, the patient will have gone into hemodynamic compromise and gone into some cardiac arrest and died. So to prevent that, I think the most integral part of our management in this case is not just administering antibiotics, but actually deciding on how to give fluids, how much to give fluids, and when to restrict fluids, etc., etc. So which means that is a real tough step, because to understand the hydration status of this patient or the intravascular volume status of this patient is extremely difficult. To look at him clinically and to judge his intravascular volume status is impossible. If he looks clinically very dehydrated, of course then you can say, but in this kind of a patient who is partly drowsy, partly oriented, to get an idea of the hydration status of the patient is almost impossible. So the most important step in this patient is fluid management. And for fluid management, the most important investigation is to look for the IVC diameter. Okay, with the ultrasound, you have to measure the IVC diameter, and IVC diameter is what will decide as to how much of fluids you have to be giving. Because the IVC is full means, of course, you know that the patient has enough intravascular volume. IVC is collapsible means still you have to be pumping in fluid and maintaining the intravascular volume. Because this is a patient who very well might be actually now in sepsis. You don't know. We are not going to the QSOFA score or sepsis going into, we're not discussing that. But patient having 160 BP, he might be going into sepsis. And sepsis, whether the patient survives or not, depends on two factors. One, how early you start the antibiotic. Second, how well you manage the fluid balance. These two things are equally important. So that is why looking out for this is the most important part. And that is where you have to look for what is called your IVC diameter. Better than looking for IVC diameters, look for what we call as the Cavell index. Cavell index is your maximum diameter minus minimum diameter by minimum diameter. That is your IVC Cavell index, which is done by your radiologist. We ourselves can do that. It's very simple to look for. Maximum diameters during your expiration, minimum diameters during your inspiration. So maximum minus minimum by minimum, you get what is called as your Cavell index. And Cavell index will actually help you as to how much of fluid you have to give. Now, this is a very important message also. Now, all of us should actually be knowing this, how to measure Cavell index. At least if you don't know to measure Cavell index, at least look for the IVC diameter. Once you know to look for the diameter, you know how to measure. So to go to a radiologist, go to your department, radiology department, ask any radiology PG, they will be able to teach you this. You can yourself be the subject and actually see how it's being done. And please know this, because in this patient, whether the patient survives or not depends upon how well his fluid status is maintained and how well his fluid status is managed. Because this case, I'll tell you the next level question in this. The next level question in this is this patient's urea being given as 180. This patient's creatinine being given as 7.2 milligram per deciliter. That is how the next level question will be. In this case, what you have to be doing is primarily taking care of these multiple things. One, fluid status on one side. Second, requirement for dialysis on the other side. And third, antibiotics. So these things have to go hand in hand. So for that, to know how to give fluids is mandatory. I'm not going to the intricacies of that. That is another discussion, altogether different discussion. But in this case, knowing the IVC diameter and knowing how to give fluids is very important. Okay, so very important question in that regard. Now, let me just tell you this again in very basic terms. Patient having fever for 24 hours. First 24 hours, there is no role for any antibiotic therapy. Next 24 hours, again, there is no role for any antibiotic therapy. Inside the next 24 hours, you have to be looking for QBC, quantitative Buffy code, at least 3 times. And if 3 QBCs are negative only, you say that there is no malaria. Otherwise, if it's malaria, you have to start treating. Fourth day means you have to start empirically 2 things. One is cotrimoxazole, because it has got very good value against typhoid, and doxycycline, because it has got good value in the case of 2 very important diseases, lepto and scrub. And 5th day is when you have to be sending for blood cultures. So this is the plan of action in the first 5 days. And NS1 antigen test is something that we do between the 4th and the 5th day. And after the 5th day, we go for dengue, IgM, ELISA. So this is our basic plan of action. And this plan of action will almost lead us to the right results most of the time. But why I'm putting up this question again and again is that everybody will know that this is scrub typhus. Everybody knows scrub typhus has to be managed, but nobody exactly knows how it is to be done. That is where you'll be caught off guard for the exam, because they may ask you something. Because in a setting like this, what are our major concerns on a day-to-day basis? In a setting like this, AKI is a major concern, ARDS is a major concern, myocarditis is a major concern, DIC is a concern. These are the concerns. Okay, and patient, because of the disease per se, going in for sepsis and septic shock. And septic shock, AKI, ARDS, myocarditis, DIC. All these are our concerns. So accordingly, we have to be looking at everything in that way. We have to be sensitizing ourselves to that. The patient develops a dip in platelet count, has a bleeding episode. You think of DIC kind of a manifestation, thrombocytopenia, which can be related to or unrelated to DIC. Patient has new onset breathlessness. Patient has a rise in tropi. Patient has an unexplained tachycardia, BP not picking up. You can think of myocarditis. New onset dyspnea, patient's saturation dropping, having non-specific infiltrates, etc. Think of ARDS. You have a patient whose creatinine is rising, his output is coming down, a tubular interstitial pattern of injury. You can think of AK. So all those things have to actually come to mind. But single most important thing is fluid balance, and for fluid balance, it is your IVC diameter, and I want every single one of you to know how to look into the IVC diameter in managing the patient. Okay, that is infection question. We come to a nephrology question now. So we have discussed a lot of the I mean, a lot of the subjects, a lot of the chapters started off with a gastro question with a hematology backup. We discussed then a rheumatology question, then we discussed a thrombosis question, infection question. We're coming to a core nephrology question. Okay, this is a question that has been already asked in our NEET PG itself. So some of you may be familiar, but I just want to discuss 1 or 2 additional points inside. It's not like an MRCP question, already asked in NEET PG, but very easy to be asked again and again. So like whenever an examiner wants to put a clinical question, the easiest 2 chapters from where he can put it are nephro and rheumat, because these are the 2 chapters where you have umpteen clinical correlations, not 10,000 and thousands of clinical correlations, because they are the 2 subjects which are most closely related to medicine, most closely related. Rheumatology is basically medicine itself, and nephrology has got one arm, that is clinical nephrology, which is so very close to medicine. Dialysis and transplant are the other 2 arms which are not directly in sync with medicine, but this particular arm is so much in sync. So let us see a female who is 36 years old, who comes to the emergency room, who is referred with renal failure of creatinine of 10. It's exactly the same question asked in NEET. So this is a renal failure, advanced renal failure with a creatinine of 10. She was comfortable at rest but looked swollen up. So she looks swollen up. These changes have happened over 1 to 2 weeks only. So very new onset. She remembers having passed high colored urine about a week ago, but ever since then output has been too low. She is catheterized but no urine. So it's a very simple case. How do you go about it? This, then I'll come to the second part of the question. So how do you look at this case now? So nephrology per se, when you see, it's all about getting the, boxes right? So syndromes are there. Where do you fit is the question. So patient can have a CKD, right? A patient can have a new onset renal failure, correct? Patient can have a renal failure on top of a CKD. So these many things are possible, correct? So when a patient has a new onset renal failure, when that new onset renal failure develops over hours to days, that is called AKI. When a new onset renal failure develops over days to weeks, you can call it as RPRF. Okay, so new onset renal failure developing over hours to days is called AKI. New onset renal failure developing over days to weeks is called RPRF. RPRF means rapidly progressive renal failure. AKI means acute kidney injury. Okay, in this particular question, there has been nothing mentioned about CKD. That means risk factor for CKD like diabetes, nothing like that mentioned. Risk factor for CKD like proteinuria, again not mentioned. CKD bilaterally small kidneys on ultrasound, again not mentioned. So why should you think of CKD here? CKD is a wastebasket diagnosis. The moment you think of this, then you have only transplant and dialysis to talk of. So naturally for your exam, they wouldn't ask you CKD. CKD is a PG level thing. They'll ask you more things which are acute. So I am not thinking of CKD in this question with the given data, because there is nothing mentioned about CKD. So new onset renal failure is what I will take. If a patient comes to me like this also, I will take up only new onset renal failure, and then I'll do the ultrasound. If ultrasound is showing small kidneys, then of course I have to accept it. Otherwise, I'll consider it as a new onset renal failure. New onset renal failure, hours to days is AKI, days to weeks is RPRF. So here it is like over a few weeks, right? 1 or 2 weeks, which means that the clinical diagnosis in this question, without any kind of a doubt, we can say that is equal to rapidly progressive renal failure. So this is a clear case of RPRF. Correct. This is a clear case of RPRF. I think that's very clear. What are the causes for RPRF? So if you look at our discussion also, you'll be knowing that there are actually speaking 3-4 causes for RPRF. The first cause for RPRF is a glomerular cause. So what is the glomerular cause for RPRF? The glomerular cause for RPRF is RPGN, so rapidly progressive renal failure, which is due to a rapidly progressive glomerulonephritis. So that is the first cause for RPRF. Second is the tubulointerstitial cause for RPRF. Tubulointerstitial cause for RPRF is severe acute interstitial nephritis. Okay, severe acute interstitial nephritis presents over a week or 2 weeks with a very rapidly progressive renal failure. Severe AIN is mostly related to drugs. Drugs is the most important cause for AIN. Sometimes you may have infection related AIN. Sometimes you may have something like a malignancy related AIN. So those things are rare, but most often AIN is secondary to drugs. Okay, and very often you attribute it to rifampicin. Rifampicin is very commonly seen associated with AIN. So many drugs can cause AIN. I've told you a big list also. But I mean, very often with respect to the exam, we think of rifampicin. Then vascular cause for rapidly progressive renal failure is TMA. TMA is thrombotic microangiopathy, small vessel disease in the kidney, which can also present with exactly like this. Like TMA, we have something called athrombotic renal disease in the elderly person, which can also present with rapidly progressive renal failure, although common to see in athrombotic renal disease is subacute onset renal failure. But still, for namesake, you can keep athrombotic renal disease also. So what are your DDs? RPGN, AIN, TMA, athrombotic renal disease. 4 DDs are there. Correct. Now, athrombotic renal disease is something that you see in an elderly person who has multiple vascular issues. On top of that, he's subjected to some angiography or something, or he's given heparin or something, and then he develops. So this picture is not fitting. So gone. Thrombotic microangiopathy should present with malignant hypertension. So hypertension is part and parcel. It's a vascular thing. Here the BP itself is not mentioned. Microangiopathy, hemolytic anemia is not mentioned. Thrombocytopenia is not mentioned. So nothing like that mentioned. TMA in a female like this, I mean, atypical HUS is the cause. Atypical HUS will have something which is striking, right? It's not presenting like this. So I am again ruling out TMA. Correct. Severe AIN, drug is not mentioned, infection is not there, malignancy is not there. So again, AIN unlikely. So I think from the given data in this question, I can only think of one thing, and that is rapidly progressive glomerulonephritis, or what we call as RPGN. Now, the other things which help me to come to RPGN diagnosis, again, I can see high colored urine, which is a glomerular thing. Patient is got swollen up, edema, which is again a glomerular thing. So even without knowing the other DDs, I can say that this patient is having RPGN. So that's quite good. Okay, we come to a diagnosis called RPGN. So very simple approach that I have followed. You can have your own ways of approaching a clinical case. There can be so many methods of approaching a clinical case. The same case, if discussed by somebody else, may discuss it in another way and come to RPGN. RPGN is the answer, but you can come to that in so many different ways. So this was the original question. In this question, the additional information that they had given, because it was a big clinical question, the additional information that they had actually given was that this patient had C1q, C2, C4, IgG, IgA on immunofluorescence with crescents under the light microscope. This is what they had mentioned. So C1q, C2, C4, IgG, IgA on the immunofluorescence with crescents in the microscope. So crescents is something that goes part and parcel, right? See, if you are seeing crescents, this is your parietal epithelial cell proliferation. This parietal epithelial cell proliferation is what we call as a crescent. Which has some fibrin and additional things. So parietal epithelial cell proliferation is called as a crescent. Visceral epithelial cell proliferation is called as a pseudocrescent. So this is a true crescent, and you can see full glomerular infiltration and full glomerular proliferation, neutrophil infiltration, all that you can actually see. And you can see the parietal epithelial cell proliferation also. So RPGN is a clinico-pathological diagnosis. Clinical part is what we have discussed here. Pathological part is the crescent. So that completes this. Now, if you want to move forward from RPGN, then you need IF, because without IF, you cannot classify RPGN. And IF based classification of RPGN is into 1, 2, or 3. Additional 4 and 5 are it's not important. 3 means you have no deposit, post-immune. So 3 means no deposit, post-immune. 3 might almost look like this. There is no deposit, post-immune. That is equal to ANCA vasculitis, correct? That is equal to ANCA vasculitis. So that is not the case. Second is type 1. Type 1 means you are having linear IgG deposits along the capillary wall. So linear IgG deposits along the capillary wall, that is equal to Goodpasture syndrome. Goodpasture syndrome, if they ask you for the exam, it can present like this, but generally when they ask you for the exam, they'll give you something in lungs. And they would have mentioned linear IgG deposits plus or minus C3 along the capillary wall. This is what they would have mentioned. Having so many immune complexes literally means that this patient is having what? It literally means that this patient is having immune complex mediated RPGN, correct? Immune complex mediated RPGN. This is where the question goes to the next level. So immune complex mediated RPGN means you are having type 2 RPGN, correct? Type 2 RPGN has how many causes? Type 2 RPGN has predominantly 3 causes. One cause is SLE, another cause is your adult HSP, third cause is your infection related glomerulonephritis or IRGN. So adult HSP can have type 2 RPGN, SLE can have type 2 RPGN, IRGN can have type 2 RPGN. IRGN is differentiated from the normal PSGN itself by the fact that IRGN is what predominant, IgA predominant, IgA predominant, IgA predominant. We've taught that 100 times. Adult HSP is otherwise itself equal to IgA nephropathy. Everybody knows, right? It is IgA, IgA. This is all IgA. Both these are very important pathology questions because they'll ask you this again and again. Apart from IgA nephropathy, where else you can get IgA deposit? It's a very common question. Adult HSP, you can get IgA deposit. IRGN also you can get IgA deposit. Some other rare cause which I have mentioned there also you can get. Which means both these settings you are not getting the other things, right? Which means the answer is SLE. And SLE is characterized by what we call full house effect. Full house effect means all these guys are going to be present. IgG will be there, A will be there, sometimes M will be there, C1q will be there, C2 will be there, C4 will be there, everybody will be there. Of which most catchy is G, A, C1q, C2. Okay, they are the most catchy. So this is actually called as a full house effect. Exact definition I'm not going into, it's not required at your level. So full house effect is what they are asking here, correct? And full house effect is seen where? Full house effect is seen in SLE. Right, so full house effect is seen in SLE, that is what they are actually looking for. Full house effect is also seen in HIV. HIV and SLE are the two classical conditions where you can get full house effect, and HIV associated with full house effect is often called as Heyde. HIV associated immune complex kidney disease. So HIV associated immune complex kidney disease is Heyde. Heyde is associated with full Full most of the time. So Heyde is there, SLE is there. Here the answer is SLE. So what all things you need to know to come to an answer here? This I think is more easier than endocrine or a rheumatology thing, because this is like a patterned discussion. No, nephrology is always like that. 2 plus 2 is 4 means it can only be 4. It cannot be 3. It cannot be 5. So you try to fix on a diagnosis first. You fix on a syndrome first. CKD, acute on CKD, and new onset renal failure. There are only 3 types. Here there is no CKD, there is no acute on CKD, so new onset renal failure. New onset renal failure over hours to days or days to weeks. Here days to weeks. What is it called? RPRF. RPRF, what are the causes? Vascular cause, glomerular cause, tubular interstitial cause. Vascular cause is HUS, it is not fitting the bill. Tubular interstitial cause, severe AIN, again not fitting the bill. So glomerulus. Glomerulus is RPGN. RPGN is, diagnosis is complete by Crescents. Okay, so that's complete, clinical pathological. Then IF, 1, 2, 3. Post-immune, linear, and then immune complex. So here they have asked for immune complex. Immune complex is first and foremost SLE itself. And SLE, what will you see? Full effect you will see. Okay, so we are correlating. First off, you may not be able to correlate so quickly, but then gradually, if you keep doing this, you will be able to. Previously, we get theory questions from this. Now also for NEET, we get theory questions from this. As we progress to the next level examination, then we are actually going to see the clinical side of this, which is much more interesting to study, because tomorrow you can get a patient like this. And you may get a lot of questions based on that. See, when a patient comes like this with a creatinine of 10, suppose they are asking you what is the next step that you have to be doing. Then that becomes a different question altogether. Next step that you have to be doing is you have to stabilize the patient first. What should you do? First, you have to be looking for ECG, because this patient with degree of renal failure may be having a hyperkalemia. So you send for investigations. Before that itself, you can do the ECG, and if you see tall T waves, you administer calcium gluconate. Second, you take a ABG and see if there is metabolic acidosis. Third, you look into the volume status of the patient, and if required, start the patient on diuretics. Correct? Then you do a dialysis in this patient. Whether indicated or not, you have to do, because of the reason that biopsy is the next thing that we have to be doing. And to prevent uremia related bleed, we have to dialyze the patient. So dialysis has to be done heparin free as much as possible, because tomorrow we are planning a biopsy. So either you can do biopsy tomorrow itself under high risk, depending on your center's policy, or you can do 2 more sessions of dialysis, tomorrow morning and tomorrow evening, 2 hours each, and then next day morning you can go for a biopsy. So these are the mandatory things. So that way, interrelated questions also you can get. Okay, but the point is, we are trying to drive home this concept of RPRF. Tomorrow, this question can be asked in so many different ways. ATT, rifampicin started, patient developing renal failure with some rash, arthralgia, etc. That becomes a hypersensitivity, type 4 hypersensitivity, which is your AIN. So that way, this question can be asked. Hypertension, thrombocytopenia, microangiopathic hemolytic anemia. So then that question becomes adult HUS. So this question can be framed in so many different ways, but the underlying point is RPRF. So that is about this discussion. Yes, this is another very interesting question. This is a question that was actually asked in INA exam, but I've slightly modified the question to make it a more clinically engaging discussion. So the question, I'll tell you the original question, and then I'll tell you what is the message they want to convey out of this question, etc. So this is again a female, 22 years old, seemingly having recovered from an episode of acute viral hepatitis. Okay, so that is the history that is given to us. We are not sure about that. She is again coming back with jaundice and transaminitis. Nothing much on clinical examination except a few healed rashes. And on probing being tested 12 years ago, this is the add-on part when we actually think of it as a extended question or as a next question or as an MRCP question. 12 years ago for some illness which is related to these rash, okay, which again we don't have enough data. This is how they give the question. So how can we interpret this question? So the first part of it is that somebody has had an acute hepatitis. Okay, acute hepatitis. Acute hepatitis is a one-time episode, correct? You are having acute hepatitis means you are having a prodrome with myalgia, vomiting, sometimes fever for 2 or 3 days, followed by severe jaundice, and you'll be having transaminitis. This is what is called as an acute hepatitis, and this is what we see. Acute hepatitis is very often due to virus, most often due to A or E, A in children, E in adults. Acute hepatitis can be due to toxins or drugs, correct? Acute hepatitis can be due to autoimmune. Acute hepatitis can be due to Wilson, correct? Acute hepatitis can be due to something like Budd-Chiari syndrome, which can present as acute hepatitis sometimes. So viruses, toxin, drug, autoimmune, Wilson, Budd-Chiari syndrome. These are the things that actually come to my mind. Pregnancy means acute fatty liver pregnancy also, but leave that. So these many things are there. The problem in our setting is, that is exactly what is highlighted in this question. The problem in our setting is we diagnose acute hepatitis very easily, but we don't do the complete workup. We assume that, okay, it is virus. Like that, we just assume. And we think it will recover because see, virus A, virus E, toxin, drug, that's a specific treatment assets, right? Most of the things. And like even if it is A, E, or sometimes even B, it is conservative management that we do most of the time. So essentially with conservative management and giving fluids and giving dextrose, etc., the patient comes out, right? So the point is that many of the time patient comes out, we don't have a diagnosis proven. We'll just say acute hepatitis and that is recovered. So if it is virus A or virus E, which are the two most important causes, the general thing in acute hepatitis is always recovery. There is no other route or other channel to actually discuss here. There is only one route, and that is recovery. And that is a complete recovery. Inside 8 to 12 weeks, there is complete recovery, right? Very few number of patients can go for what is called as a fulminant failure, fulminant hepatic failure. That means inside a week of developing jaundice, they may develop encephalopathy and coagulopathy. That is fulminant hepatic failure, which requires transplant and all that, which is mostly related to some toxin or drug or your rat killer poisoning, sometimes extreme paracetamol poisoning, etc., etc. So all that we actually know. But here we are seeing a very strange case. What is that strange case? Coming back again. What is this coming back again? Can acute hepatitis come back again and again? How is it possible for acute hepatitis? Does acute hepatitis relapse? It doesn't relapse like that. Hepatitis B flares means on top of an underlying chronic hepatitis B, you are having flares. That is a different thing altogether. Can acute hepatitis relapse? So that is why this question becomes a crux question. Means you need to be knowing something to answer this question. So can it relapse? No, none of these things actually relapse. What is the meaning of relapse? I mean, if you treat and then it goes away and then comes back, that is a relapse. Here it is like nothing is being done, it's going and coming back. So let us see the question again. 22-year-old female coming with jaundice and transplant. So I would probably put it as a acute hepatitis that is not recovered. Okay, that is not recovered. Or you can say waxing and waning of jaundice, correct? Waxing and waning of jaundice. These are two things which I probably can put up. Then I read the question further. She has a few healed rashes which were probably treated 12 years ago. Rash again. So I have to come up with this autoimmune thing. And now the bill is perfect. Young female is there. Autoimmune, some kind of history is there. Rash maybe because of SLE, because type 1 autoimmune hepatitis is very closely linked to SLE. So it may be associated with SLE. On probing 12 years ago, she may have been treated for the same thing. And acute hepatitis, which is due to autoimmune, if you unless and until you give steroid, it will not recover, it will go and come back. And that is actually typically called as the waxing and waning of jaundice. So all that taken together now, I probably think that this could be a case of autoimmune hepatitis, but that is not 100%. I feel like that right now. The question that was asked in this particular case was this, then we'll come back. The question that was asked in this particular case was on this image. And this image is what was most importantly asked. Identify this phenomenon and what is it characteristically associated with. This phenomenon of one cell engulfing another cell is what we call as emperipolysis. Okay, it's a pathology question that is called emperipolysis. Emperipolysis is more or like a phagocytosis, but phagocytosis means you kill it, right? Here in the cytoplasm, you can actually see another cell surviving. This is called emperipolysis. And what is characteristically associated with emperipolysis is autoimmune hepatitis. So from that question, you get clues, but that question has to be clubbed with this image to get the idea. Correct? That question has to be clubbed with this image to get the idea. They have given this much detail and then they have actually given this image. So when they have given that much detail and then the image, then that becomes a complete question. So they want you to know that this is acute hepatitis. In acute hepatitis, generally it is recovery. So jaundice going and coming back means you have to think of autoimmune, waxing and waning. Again, young female with some history of some rash or some treatment, again is pointing towards autoimmune. This emperipolysis is again pointing towards autoimmune. So all that together means you have to be thinking in terms of autoimmune hepatitis. Right. Now, if I were putting this question, I would have definitely given data on the antibodies. And that's why very important to keep in mind, anti-actin antibody, anti-soluble liver antigen or SLA antibody, anti-smooth muscle antibody. These three antibodies, please keep in mind, they are the characteristic three antibodies in autoimmune hepatitis, which if unless otherwise mentioned is type 1. Type 2 autoimmune hepatitis is a childhood autoimmune hepatitis, about which a clinical question is very unlikely. It is more severe. That is one thing you can actually always remember. Even relapses are very common after drug withdrawal. It's a bad disease. And inside that, the two antibodies that you have to keep in mind are anti-LKM1 antibody and anti-liver cytosol 1 antibody. So these are the two things that you keep here. Here also P and K is there. So P and K, anti-smooth muscle antibody, anti-soluble liver antigen, anti-actin antibody. So these are the other two things. Okay, of which actin, soluble liver antigen, and anti-smooth muscle antibody, very important. Okay, clear. Now, in that question, the other two options that they had put up was PBC one option, PSC one option. So, PBC one option, PSC one option. What is PBC? PBC is primary biliary cirrhosis. Okay, primary biliary cirrhosis. What is PSC? Primary sclerosing cholangitis. So, primary sclerosing cholangitis. Correct. So primary biliary cirrhosis, primary sclerosing cholangitis. Now, some of the people actually felt like they get confused with this, no, right? They get confused whether it is PBC, PSC, or autoimmune. But if you feel that PBC or PSC is the answer to this question, that means that your understanding is completely wrong. Okay, completely wrong. Now, again, you can get questions like this. So please make it clear for once and all that PBC and PSC are two diseases which are characterized by cholestasis. Yes, they are associated with cholestasis. That is the key term there. Because PBC is a autoimmune inflammatory destruction of the intrahepatic bile duct. Okay, autoimmune inflammatory destruction of the intrahepatic bile duct. Now, when it is an autoimmune inflammatory destruction of the intrahepatic bile duct, PSC is a fibrosing destruction of the intra and extrahepatic bile duct. So, this is an autoimmune inflammatory destruction. This is an intrahepatic bile duct destruction. That is a fibrosing destruction of the intra and extrahepatic bile duct. Here, LFT, I mean transaminases, in most cases is almost normal. It's like just maybe slightly raised, but not significant. What is significant is alkaline phosphatase. Yes, alkaline phosphatase. So here you are talking about what is called intrahepatic cholestasis. Yes, intrahepatic cholestasis. Correct. So you know both are going to be strikingly so different from autoimmune hepatitis. These two diseases are going to present with fatigue. Fatigue is the most common presentation, then pruritus. So fatigue and pruritus are going to be present in your case. Correct. This is how do you differentiate between these two means PBC will be around 40 years of age, will be a female 100% because the female male ratio is 9:1 and very often associated with Sjogren syndrome. This is how you figure it out. PSC on the other hand is also around 40 years old, but is going to be a male patient who is definitely going to have inflammatory bowel disease because PSC goes hand in hand with IBD. So here the association is Sjogren, here the association is IBD. Okay, here you have this anti-mitochondrial antibody that itself will seal the deal for you. Don't have to think of anything more. Here you require a MRCP, magnetic resonance cholangiopancreatogram, to make a diagnosis. Correct. Here it is very responsive to ursodeoxycholic acid. It's almost changing the fate of patients with PBC. So many new drugs are also there. Here it is almost like you require a liver transplant. Okay, so ursodeoxycholic acid people who respond are doing well. Here you require a liver transplant. This is a fibrosing condition. PBC is an inflammatory condition. Here you think of Sjogren, here you think of IBD. Okay, so please don't confuse this. Autoimmune hepatitis on one side, PBC on the other side, PSC on the other side. Okay, the three are having three different patterns of presentation. Here mostly you will be getting a patient who has acute hepatitis with ALT, AST high. Here you will be getting a patient with fatigue and pruritus. Here also you'll be getting a patient with fatigue and pruritus. If there is associated autoimmune Sjogren involvement, mark it as PBC. If there is IBD male involvement, think of PSC. And PSC is now thought to be one kind of IgG4 related disease. It is now so many diseases are coming under this bracket of IgG4 related disease. PSC is actually the latest addition to this bracket of IgG4 related disease. So in this question, the mistake is that we assume everything is viral without having evidence. That is why when you treat a patient with acute hepatitis, it is very important to assimilate evidence, and that evidence can actually help us to treat further. Okay, so it's a very simple question, but you can take this question whichever way you want. I have deliberately not taken it into too many directions because I don't want to confuse you in the first discussion itself. I'm trying to keep the discussion simple. So we can take it into so many ways, but with this much data, this is a question asked. This is what is expected out of you. Right, yes. We go to question number 7. Okay, this is a 19-year-old girl who presents with acute onset ascending paralysis. This is a USMLE question. Okay, ascending paralysis of bilateral lower limb for 3 days with weakness in the upper limb and head lagging for 1 day without paresthesia or loss of sensation. No history of fever, URTA, UTI or diarrhea before the illness. Okay, examination shows hypertonic limbs with areflexia. Nerve conduction velocity shows normal snaps, reduced maps. So amplitudes, normal latency, normal conduction velocity in both upper and lower limbs, and what antibody is involved in the disease, and if classical dissociation with proteins, what additional investigation is mandatory. So, albuminocytological dissociation is what we actually talk about. Lumbar puncture CSF analysis was performed, and what is actually being expected to see, and so many such things. How do you approach this case? Okay, so how can we approach? Let me just try to look at this case, and we can look at this case in so many different ways. But young girl, acute onset weakness. Okay, young girl, acute onset weakness. This much you can write, correct? First, bilateral lower limb weakness for 3 days. So, acute onset weakness, bilateral lower limb into 3 days. Now, I'm stopping at that point. I'm not looking for the progression, just cutting short. And I'm coming here. What am I seeing? I'm seeing that the patient has hypotonic limbs with areflexia. Okay, hypotonic limb with areflexia. So, LMN weakness. So, this much is very clear now. Correct? LMN weakness. Okay, that much is clear. So, young girl, acute onset weakness, bilateral lower limb, LMN weakness. LMN weakness, where can I place the patient? Where can I place the weakness? I can place the weakness in the anterior horn cell, because that is where LMN starts. I can place the weakness in the radical. Okay, I can place the weakness in the ganglion. I can place the weakness in the nerve. I can place the weakness in the neuromuscular junction. I can place the weakness in the muscle. These are the common sites I place. Okay, here it is very clearly mentioned that the patient has progression to upper limb, head lagging, all those things. There is some progression is also mentioned. We are not looking into that right now. Anterior horn cell, it is not anterior horn cell, but why it is not anterior horn cell? Anterior horn cell will have asymmetry, correct? It is chronic, it is progressive. Chronic progressive asymmetry with fasciculations, correct? Wasting. So, it's a completely different picture, correct? So, anterior horn cell I can just like that strike off. Fine. Radical ganglion, etc. Ganglion is pure sensory, like sensory attacks it will come. Radical will have a very predominant sensory component. Nerve will have a very predominant sensory component. So, all that I have told you, we take it out. Just like that, take it out. Correct? Fine. Right. NMJ, if you see fluctuating weakness, extraocular muscle weakness, ptosis and diplopia, nothing. Correct? So, what is remaining? Muscle is remaining. Correct? Muscle can be said as a pure motor weakness. Pure motor weakness. So, pure motor weakness in muscle, whenever you are having persistent weakness, you think of muscle dystrophies, etc. But here, it's very short history. So, you can't think of any muscle dystrophy or anything. Acute onset muscle weakness will also be like proximal muscle, right? It cannot be like so fast ascending that way. So, which means muscle is also not fitting into this picture. So, then what am I left with? I have discussed almost everything, but nothing is fitting into my picture. So, acute onset weakness, bilateral lower limb LMN. I need to think of bilateral radiculoneuropathies, correct? Bilateral radiculoneuropathies, which can be causing axonal weakness or it can be demyelinating weakness, whatever it is. So, bilateral radiculoneuropathies, that is one thing. Spinal cord involvement, but spinal cord involvement we have studied is what? Is UMN, right? It is not LMN, bilateral spinal cords, but spinal cord involvement occurring very acutely, so the patient can be in shock, that is also there. Very acutely involving spinal cord involvement is called acute transverse myelitis. So, yes, can this be acute transverse myelitis? One possibility. Bilateral radicular neuropathy occurring very acutely, what is the answer? GBS is the answer. GBS can have a demyelinating way, that is AIDP, or it can be Aman-Amsan, which is axonal. So, GBS is one side, transverse myelitis is another side. So, when you get a question for the exam with a patient coming like this, although we go anterior horn cell, nerve, muscle, etc., don't look into any of those things just to see whether it is GBS or transverse myelitis. Nothing else you need to see for. That is the first most important message. Second most important thing I want you to know is why this is GBS or why this is not transverse myelitis, or why it is transverse myelitis and not GBS. You have to be seeing. First point is, whenever you hear the word ascending weakness, okay, ascending weakness, you think of GBS. Whereas if they mention paraparesis, quadriparesis straight away, then you think of transverse myelitis. So, the word ascending weakness is very important. Okay, and upper extremity weakness, okay, is less severe in GBS in comparison to lower extremity weakness. Means lower extremity will be 0/5, upper extremity will take its time. So, it's like less severe. Second, definite level. When you hear this word level, then you know that 100% it is transverse myelitis. Here there is no level. And 2 to 3 days prior to the weakness, you may be having some sensory symptoms. That is all. In this case, even that is not mentioned. Okay, so that is the second point. Whenever you are having a definite sensory level, then that is transverse myelitis. Third, bowel bladder early involvement is always transverse myelitis. So bowel bladder early involvement is always transverse myelitis, but autonomic nervous system involvement, especially with respect to your CVS, is very, 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 very important in the case of Guillain-Barré syndrome. We have even reported cases of present Guillain-Barré syndrome due to fluctuations in BP, your orthostatic hypotension, tachycardia. So cardiovascular system-based ANS manifestations are always equal to GBS. Routine manifestations like urine urgency, retention, all those things in transverse myelitis. So that is number 3. 4 is the moment you get cranial nerve involvement. The moment you get cranial nerve involvement, then you think of GBS. There is no cranial nerve involvement in transverse myelitis. Okay, so these 4 things be very, very clear. Here in this particular case, I basically can't think of transverse myelitis because again, definite level is not there. Definite sensory loss below that level is not there. Motor involvement will be LMN at that level, that is again not there. UMN below that level, again that is not there. So because of which on the whole transverse myelitis looks extremely, extremely unlikely. So with this much of data, probably I think the diagnosis is GBS. In this USMLE question, they have gone one step ahead, which may not be required at your level, but still what they have gone ahead is GBS is a demyelinating condition, which means velocity should be affected, correct? But here velocity is not affected. In fact, it is the amplitude that is affected. So when it is amplitude getting affected, then it is axonal. So some people may think it is not GBS. But as you know, there are 4 types as has been shown here very clearly, of which Aman and Amsan are axonal types, of which Aman is seen classically in young adults, and it is characterized by these antibodies called anti-GD1A antibodies. So anti-GD1A antibodies, young adults, Aman. And most important thing is that you may get this albuminocytological dissociation in GBS. It's not very classical, but if there is no albuminocytological dissociation, it means that always check for HIV. No albuminocytological dissociation, and that means radicals will always leak proteins. So proteins will be there, but cells won't be there. If you're seeing cells, then always think of HIV. So 2 additional points they want you to remember, that Aman is the diagnosis they're looking for. Anti-GD1A is the antibody that you're checking for. And in this context, when albuminocytological dissociation is not there, we always think of HIV. Okay, so the weakness approach has to be pakka, which means that when you are seeing chronic weakness, when you are seeing acute weakness in the LMN context, okay, sensory motor weakness and pure motor weakness. Sensory motor weakness means you think of nerve, you think of your root, correct? Pure motor weakness means you think of anterior horn cell, you think of muscle, you think of neuromuscular junction. Acute setting, don't think too much, think of GBS versus acute transverse myelitis. This is the complete roadmap. Okay, you can get different questions from this, but most classical questions that you get from this are going to be GBS, transverse myelitis, and hypokalemic paralysis, which may actually simulate a GBS, but later we'll be finding out some other cause for that. Okay, that's about this. Then we come to another question. This question is again a question which I first saw in a quiz competition, in a quiz program, and I found that this question is a very interesting question. So that's why I thought of just coming up with this question. Elderly male, so most of the cases we discussed where there are females here. So elderly male coming for colonoscopy, okay, is admitted for colonoscopy, suspecting malignancy. Why suspecting malignancy? Elderly male having any kind of lower GI symptoms, first thing that comes to mind is malignancy. He had fatigue and melena, that's more than enough. So fatigue and melena, maybe some hematochezia also. So he is being admitted for colonoscopy, fine. But now on admission, he admitted that having syncopal attacks multiple times over the last 1 year. So maybe anemia related, blood loss related, we don't know. Cardiac evaluation before colonoscopy led on to, ECG findings led on to the echo, and echo was a surprise. Okay, so this is the quiz question. So quiz question wants you to finally give you the diagnosis. So I'll just give you the images with that question. First is this image, which is a ECG. Okay, what does this ECG tell us? So this ECG, if you look into the rhythm strip, you know that QRS complexes are there. Each QRS complex is a narrow QRS complex, which is preceded by a P wave. And this QRS T with the P wave is coming naturally, regularly. So it's coming naturally. So it's like regularly. So it's like a person who is in normal sinus rhythm. So you know that. In this normal sinus rhythm, what are the issues? Issue number 1 is that you are having very tall R waves in V5, V6. very tall R waves in V5, V6, and you're having deep S waves in V1. So tall R waves in V5, V6 with deep S waves in V1, V5 or V6R plus V1S is more than 7 boxes. So this is equal to LVH on the ECG. So so-called line index is satisfied. You're having LVH on the ECG, and it's not just a simple LVH. You're having strain also. See, you're having LVH with a descending limb and ascending limb, which is disproportionate. This would be more of ischemia type. This is more of a strain type. So this is a strain type thing. So strain type. So LVH is there. Correct. Patient has an axis between 1 and AVL, because between 1, 2, 3 AVL, AVF, tallest complexes are there in 1 and AVL. So 1 and AVL means you're having a leftward axis. Correct? Leftward axis, 0 to minus 30 degree. It's a leftward axis. Leftward axis is there, LVH is there, slightly wide complexes in 1, correct? Slightly wide complexes. So you can say left bundle branch morphology. There is no left bundle branch block or anything. Left bundle branch morphology is there, LVH is there, leftward axis is there. Something really happening on the left hand side. So much of left ventricular hypertrophy, disproportionate left ventricular hypertrophy. We have not been given that he is having hypertension for a long time. So if you get a ECG like this, first of course, what you will think is hypertension with inappropriate LVH, and maybe like appropriate or inappropriate depending on the age. He's 72 years old, so maybe even appropriate also, having hypertension for a long time. Then you can think of something that is causing that much degree of LVH, correct? That much degree of LVH. So that led on to the echo, it seems. So echo is a surprise. Second, they showed a colonoscopy result also, and the colonoscopy is showing full dilated vessels. This is angiodysplasia. Okay, this is angiodysplasia of the colon. So this angiodysplasia of the colon is given. LVH is given on the ECG. Now you are asked to find out the answer. This is maybe a slightly higher level question, but when you get a clinical question, there are so many angles that you study in this. Okay, final diagnosis is not that what is important. This echo was a total surprise. The syndrome everybody knows, but when it is asked like this, I don't know how many of you pick it up. And the patient had syncopal attacks also. When you have this degree of LVH in a 72-year-old person who is not having hypertension, there is only one thing that can come to your mind, and that is aortic stenosis. Aortic stenosis has LVH on the ECG, LVH on the echo, massive LVH on the echo, because the output is maintained by the left ventricular hypertrophy. So that is the reason for LVH. Syncopal attacks are because of fixed cardiac output. Yes, because in aortic stenosis, the output does not increase with exercise. So it is a fixed cardiac output state. And you know that A, S, D are the 3 cardinal symptoms in aortic stenosis. A stands for angina, S stands for syncope, and D stands for dyspnea. And the patient has all that. AS patients may sometimes have angiodysplasia of the colon. Angiodysplasia of the colon that you see in AS patients is what we call as the famous Heyde syndrome. So here they have asked for Heyde syndrome. It's a quiz question. In this quiz question, they have asked for Heyde syndrome, but again, very likely to come as a clinical question. It's not about finding out Heyde syndrome. It's not about knowing that angiodysplasia of the colon with aortic stenosis is equal to Heyde syndrome. That is not the purpose of the discussion. The purpose of the discussion is whether you can reach this echo finding with the ECG. The ECG finding is LVH. You are having fatigue. You are having an elderly person. You are having bleeding also from the GI. So together, are you able to correlate everything and come to the diagnosis of aortic stenosis? Because aortic stenosis question can come in 2 settings. One way aortic stenosis question can come is a young patient with a bicuspid aortic valve. Correct. Second way aortic stenosis question can come is from a degenerated calcific valve. So degenerated calcific valve means patient will be definitely above 60 years. Bicuspid aortic valve means the patient will be somewhere around 30 to 40 years. So these are the 2 patients whom you can get. Both of them, the cardinal symptoms are going to be A, S, and D. Angina is because of LVH predominantly, and also because of the fact that the capillary wall density with respect to muscle thickness ratio, that is altered. Syncope is due to a fixed cardiac output state. And by the time you are having dyspnea, then things are getting bad. Okay, that's how we say ASD 532. 532 means if you don't do surgery within this period of 5 years, 3 years, or 2 years from the onset of the symptom, patient won't survive. Dyspnea is again because of LVH. LVH is equal to increase in LV end diastolic pressure, which is equal to an increase in LA pressure. So that is how it translates into dyspnea. So because LA pressure is equal to pulmonary capillary venous pressure. So that is how this whole thing is. It's slightly tough question, but I still feel that if you know the correct connects, then you are actually in business. Okay, so please study AS. You know all the theoretical points about AS, but this ECG should make you think in that direction. That is what is expected. Okay, next question. So we have been discussing, I think, a little bit of cardio, neuro, gastro, liver, hemat, and of course, nephro. We'll just see one question. It's more of endocrine question. So this is a tricky question. Okay, the real tricky question. Tricky question just to know again whether you have worked in the hospital. That's all. Diabetic patient who is very well controlled, okay, who is well controlled on OHA alone, that is on dapagliflozin metformin combination, with a HbA1c of 5.6, so very, very good control. Presented with lightheadedness, okay, lightheadedness, as he was kept NPO for a dental procedure. So kept NPO for a dental procedure, lightheadedness, vomiting and tachypnea also. So vomiting, tachypnea also. Capillary blood glucose was 120. So expecting hypoglycemia, but there is no hypoglycemia. What's happening? Let's see. Parameters. pH is 7.25. So acidosis. Bicarbonate 10. So there is metabolic acidosis. Anion gap 23. So that is high anion gap metabolic acidosis. Potassium 4.9. So that is normal. Ketonemia plus plus. So there is ketosis. So this much data is there. It's a very simple, straightforward question. Let us see how many of you can answer this. It just tries to check out for your sense, basic sense. So many people on seeing this have a tendency to think that this could be a case of diabetic ketoacidosis with some chronic sepsis. We don't know what is the cause. So probably the patient has sepsis, and because of that, some people think this is starvation acidosis because the patient was kept NPO, so had a starvation acidosis. Those are two things that people can think, and I think most of the people were thinking in terms of diabetes. But this is a very easy, very easy question. Just think of this question now. Patient is having diabetes but very well controlled and CBT is normal. So you have to think out of that. Patient has been kept NPO for a dental procedure, so that may have probably precipitated this. Correct? Presented with lightheadedness, vomiting and tachypnea. So that's mostly related to ketosis and metabolic acidosis because of ketosis. What has precipitated that? DAPA metformin combination? Yes, DAPA metformin combination. Of which what? DAPA or metformin? DAPA. Yes. This is a case of euglycemic ketosis, which is produced by SGLT2 inhibitors. The most important side effect of SGLT2 inhibitors that all of us need to know is euglycemic ketosis. This is a typical example of euglycemic ketosis that is caused by DAPA, that is precipitated by the patient being NPO since morning. So it's a case of euglycemic ketosis. It's actually speaking very easy question for an intern who has seen somebody like this, but otherwise you may have this tendency to go and write it as DK. This question is actually framed in one of the exams long back, for 4 years, 5 years back, and then was asked in so many different ways. So this is basically to tell you that whenever a patient is on DAPA, you have to be thinking of one, mycotic UTI, because it does precipitate infections in the urine, especially fungal infections. Second thing that you have to be thinking of is osteoporosis, because some degree of bone damage has been reported. Third is ketosis, which is classically euglycemic ketosis. So these are the three things that you have to keep in mind. But the advantages that dapagliflozin or these SGLT2 inhibitors have are like huge, immense, that the advantages are. So because of it, you have to be using it. And now DAPA is like not just for controlling diabetes, it is like a cardio-metabolic drug more than anything else now. It is useful in patients with systolic heart failure, that is heart failure with reduced ejection fraction. It is among the fantastic four. It is now being used in a big way in NASH. It is being used to control proteinuria in patients with diabetic nephropathy. So part of metabolic, cardio-metabolic control, this drug is actually working lots and lots of wonders. So overall, a drug which we can't do without. Okay, overall a drug which we can't do without, but we have to be specifically looking out for two things. One is urinary infections, second is ketosis. So recurrent urinary infections, you should be watching out for that, and ketosis also you should be watching out. It's a very simple question, but making you think in a particular direction to get that right. And always keep in mind the advantage that this drug has are immense, and I have actually done a module on that, even that's like the advantages, because see, this is kind of increasing the load that is being delivered to the distal tubules and especially the macula densa, which leads on to afferent arteriolar constriction. So when there is afferent arteriolar constriction, that actually decreases the hyperfiltration. So because it decreases hyperfiltration, it is able to reduce proteinuria. It's a very important thing. And then it produces natriuresis, it produces diuresis, but no tachycardia. So natriuresis is there, diuresis is there, no tachycardia. And then it blocks a lot of these inflammasomal pathways which are pivotal in atherosclerosis. So because it blocks these inflammasomal pathways, it can be useful in preventing atherosclerosis. So because of which, on the whole, you can almost call it as a wonder drug, really wonder drug. So canagliflozin, dapagliflozin, empagliflozin. Dapagliflozin in diabetes, please start at 5 mg and then you can go up to 10 mg. Empagliflozin, you can start at 10 mg and you can go up to 25 mg. Always watch out for two questions as far as clinical questions are concerned. One is this question, euglycemic ketosis. Second is recurrent UTI, of which especially fungal, mycotic UTI. Okay, that is this. Now we go to the next question. 35-year-old male presented with intracranial bleed to the neurosurgeon but had a retained GCS. So it's like a mild bleed. But on evaluation then, his platelet was only 7,000. No infection, nothing but platelet only 7,000. Hemoglobin was 8 and total count only 1,200. Smear was very much in line with our expectation. What is the dreaded complication in this disease was the question, and that was another clinical question which I will discuss later on at another point. And the clues are PT, APTT were raised. Can you read everything together is the question. And you can see these classical cells. I will just introduce you to the cells also later on. So this is the cell that you are actually seeing in picture. Okay, fine. You may not get it on the smear, okay? Mostly you may have to do a marrow to get it, but in this question they've given smear. With the big cells, it's hard for them to go out of the marrow to the blood. So they're mostly in the marrow, but we will see. What kind of a question is this? Very interesting question, very, very important question also. So even if you forget that bleed and all those things, you know that this patient has a pancytopenia. Yes, this is a pancytopenia. So when you have a patient presenting with a pancytopenia, the first investigation itself is a bone marrow. So without bone marrow, there is nothing to discuss about in pancytopenia. Everything is based on bone marrow. But suppose we don't have a bone marrow, like now, when clinically we are asked to give our opinion on a patient who presents with pancytopenia. We don't know the duration of pancytopenia, but in this case, I think it's short duration. He's a very, very young patient. Every pancytopenia, the first thing that comes to our mind is definitely leukemia. So definitely leukemia. So pancytopenia presentation, acute leukemia is the first thing that has to come to our mind. No doubt, no second thoughts on that. And which can be AML, which can be ALL, which can be APML. So these three things are there. AML, myeloid, lymphoid, or promyelocytic. So these three things. This would be the first thing that will cut across our mind. Everything comes after that. Everything comes after that. Let me make it very, very clear. Now, apart from this, what else? Now, if you are talking of a patient maybe 55, 60 years old, I would think MDS. MDS is common. MDS is common to see. MDS can be of a hypercellular type or the hypocellular type. Either way it is, but MDS would be number 2. Bone marrow failure, aplastic anemia. Aplastic anemia would be number 3. So aplastic anemia, of course. Primary myelofibrosis. Yes, primary myelofibrosis again. So these things are the general hematological conditions. I can also keep in mind PNH, yes, which can present with a hypercellular, cellular, or even a acellular marrow. So primary myelofibrosis, PNH, aplastic anemia, MDS, all these things actually come to my mind. But still, up and above all that, it is leukemia, leukemia, leukemia. Now, post-viral transient cytopenias are reported, but they will recover by themselves. They will generally recover by themselves. They are not serious enough to cause this level of things. So when you know all these things, okay, when you know all these things, and you know that all these things can present this way, and we need to straight away go to the bone marrow. From this picture, does anything mean? Are you thinking of anything else? Is it common for a patient with a leukemia, myeloid or lymphoid to come with a bleed, and that too in the CNS? Is it common? Not at all common. They may have low platelets, but they generally tend to do okay with that. May have petechia, purpura, something, but to have full-blown bleed, is it common? No, not common. So then what is it? Let us see the cell. This is the cell in question. I'll just try to take the cell in a bit more detail. One, heavily cytoplasmic granulations, no? Granules. They generally stain red or purple. You may not even see the nuclear border because of that. Then OR roads, right? Then eccentric nuclei, round eccentric nuclei. Moderately condensed chromatin. And nucleoli not visible. Yes, nucleoli not visible. Yes. This is what we actually call as more or less some people call as a flower cells also. This is the promyelocytic cells in APML. Yes, the classical promyelocytic cells in APML. And when you actually see CD13 and CD33 are their two markers. That is how, and they are classically HLA-DR and CD34 negative. That is like another very important clue that you get. And you know that these are promyelocytes. Now, why I'm stressing on this, that a promyelocytic leukemia, very, very important, is because promyelocytic leukemia is a disease which has almost 90 to 95% survival. 90 to 95% survival. And can be treated without chemo, as all of you know. It can be treated without chemo. Our classical AML 7+3 cytarabine domagrozin regimen doesn't actually apply to promyelocytic leukemia. And promyelocytic leukemia in this era, this age, is treated with ATRA, that is your all-trans retinoic acid with arsenic trioxide. This is how you treat promyelocytic leukemia. Then you have the high risk, low risk, and all, which we've discussed in detail depending on the WBC count and that, and idarubicin added, subtracted. That and all I'm not discussing now. But this is a disease without chemo where you can get this much success. But the problem is early mortality. That is why this is very, very important to understand. The problem with promyelocytic leukemia is all about early mortality. Why do patients with promyelocytic leukemia have that high level of mortality? Is because of these three complications which you see in a promyelocytic leukemia, which are generally not associated with other forms of leukemia. And that is why they're again and again asked for the exam: DIC, differentiation syndrome, and intracranial hypertension. DIC, differentiation syndrome, and intracranial hypertension are three classical complications of promyelocytic leukemia. Early death in promyelocytic leukemia, early complications in promyelocytic leukemia. If you get a clinical picture, please think of these three things. First and foremost, DIC, because these granules release thromboplastin, right? Because of which there is disseminated intravascular coagulation. That is why the patient can bleed. But at the same time, the patient can have thrombosis also. It is bleed that is more common than thrombosis. So if they give you that PT is high, APTT is high, platelet is low, fibrinogen is on the lower side, fibrin degradation product is on the higher side, just jump and mark the answer as DIC. Okay, and early DIC within the first 30 days, very likely. That's why some of the patients with APML don't really reach us. Before that, they die. That is because of DIC. Second is this differentiation syndrome. Differentiation syndrome, especially soon after starting this all-trans retinoic acid, or sometimes even starting arsenic trioxide, you get this differentiation syndrome. Differentiation syndrome is typically characterized by endothelial injury. So because of this endothelial injury and vascular leakage, edema, lung infiltrates, fever, hypotension. Okay, this is the classical picture of which fever, lung infiltrate, edema. If you get a fever, lung infiltrate, edema question, duck, mark the answer as differentiation syndrome. That is the second one. And then if the patient has any kind of headache and visual blurring, okay, headache and visual blurring, please mark the answer as BH, idiopathic intracranial hypertension or benign intracranial hypertension. So those are three things which are very, very unique to promyelocytic leukemia. And all of you know promyelocytic leukemia is actually characterized by this 15-17 translocation, what we call PML, RAR alpha translocation, and all that we have discussed in great detail. The importance of this PML, RAR alpha translocation and all that, and the other translocations in AML, including inversion 16, 16-16 translocation, and 821 translocation, and all that. So that is not the point of discussion. This is what we are actually looking for, these three clinical things, because in a clinical question, how you think of APML is when you are smelling DIC, think of APML, smelling differentiation syndrome, think of APML, smelling idiopathic intracranial hypertension, think of APML. Okay, in aplastic anemia also I have taught you this. Aplastic anemia, after giving this ATG cyclosporin regime, also some patients have developed, I mean, something like a intracranial hypertension. So those things are there. So this is a very, very, very important question. So this question, though from the outside looks very benign, but in reality, there are so many more angles to this. And how you treat it is something that we have discussed in detail. Remember, the base is these two drugs, atra and arsenic trioxide. Okay, they're differentiating agents, but in high risk patients, we do add idarubicin also. Okay, idarubicin also we add, and CNS prophylaxis plus or minus depending upon whether there is any leukocytosis, intracranial hemorrhage, etc., etc. Generally, treatment is arsenic trioxide plus all-trans retinoic acid. This is a big change because of the reason that AML was previously like M1, M2, M3. Now we don't use that. AML and APML are two different diseases. AML 5-year survival still with all what we have and transplant and all that is still less than 20%. Okay, 10 to 20%. But APML we have gone to a rate of 90 to 95%, which is extremely good. Which means the patients whom we are not able to get into this 90 to 95 are the people who die early, and that is primarily because of DIC. And that is the most important clinical factor. Everybody knows AML M3 has DIC. Even AML M3 is a wrong term. Everybody knows APML has DIC. But when it comes as a clinical question, you should be sharp enough to point it out and come to a conclusion. Okay, so we go to another question, which is contributed by one of our own students from AIMS. He has made it a bit more tricky. This is one problem we face now in INA exams, especially because when the HOD is confronted with the task of setting up a question and he designates it to one of his juniors, the junior, more than trying to frame the question, is more concerned about impressing the HOD. So in the process of impressing the HOD, he tries to frame a slightly indirect questions. But let's try to take the crux of this. So this is a question of a female, 35 years, who is undergoing therapy for some disease. Okay, some disease, and the drug is the question here. Okay, and she has presented with altered mental status and progressive limb weakness. So two areas are there. Altered mental status is there, progressive limb weakness is there. Limb weakness they have given is because of hypokalemia, and they have also given hypocalcemia. Okay, and they've given a lot of results. Positive urine anion gap and stuff, so and so, and they've given an MRI also. Okay, this MRI is also there. So which is basically showing T2 hyperintensities. Yes, hyperintensities are there. Okay, great. Other sections and all not there. Fine. So we can attack this question in so many ways, but I think a very convenient mode that we can take, because the evaluation is very important and we have discussed it in great detail and everybody has discussed that, and it's so important for the exam, NEET or IN or whatever they keep on asking, is hypokalemia. So essentially this is a case of hypokalemia, and they have themselves mentioned it as persistent hypokalemia. So persistent hypokalemia evaluation. Persistent hypokalemia evaluation, step number 1 is whether it is non-renal or renal. And I've told you any hypokalemia that is significant enough to produce a weakness is almost always renal, but sometimes can be non-renal. To differentiate, you require urine spot potassium, but again, urine spot potassium or urine spot potassium by creatinine ratio. This urine spot potassium creatinine ratio or urine spot potassium is not given in the question, but any clinically significant potassium, see 2.8. 2.8 can be even non-renal, but it's so clinically significant and they're asking for the exam is to be taken as renal. So this is renal. Renal hypokalemia can be divided into two depending on whether there is acidosis or alkalosis. So there is acidosis or alkalosis. What I'm talking of is metabolic acidosis, metabolic alkalosis. So this question, they have given 7.32, which is metabolic acidosis. 7.4 is fixed. So 3.2 is acidosis. If they had given metabolic alkalosis, then our discussion would have been totally different. So I'm not going to the time being. Metabolic alkalosis with no hypertension and hypertension, right? No hypertension, or what we say, normal to low BP. Normal to low BP should always make us think of Bartter syndrome and Gentleman syndrome. So those are the two things that you have to think of. They are inherited conditions likely to present in younger people and not fitting the bill. Hypertension means endocrine conditions should come to mind, especially Conn's syndrome, Liddle syndrome, Cushing syndrome. These are the three most important things. You can also think of AME, GRA, etc. Apparent mineralocorticoid excess, glucocorticoid remediable aldosteronism, but that's all different discussion, not at this point. You can see the discussion, I mean, in endo, hypokalemia, etc. That's not for this case. So this case, this is not applicable because what they have given is metabolic acidosis. So now the case becomes very, very easy. Now, if you know that anybody who has significant hypokalemia with renal loss mostly and having metabolic acidosis is equal to RTA, that itself gives you the diagnosis. Anybody having hypokalemia with significant hypokalemia, persistent hypokalemia with metabolic acidosis is equal to renal tubular acidosis, which can be RTA1 or it can be RTA2. So in this case, without any difficulty, you can say that it is equal to renal tubular acidosis. Correct. So this I have said, so many of the teachers have taught you that any hypokalemia with renal loss with metabolic acidosis is equal to renal tubular acidosis, and that is 1 or 2. RTA4 we are not discussing it because that is hyperkalemia. RTA3 does not exist, so only RTA1 or 2. So what is RTA1, what is RTA2? Quickly, to just get into the crux of the question. RTA1 is a distal RTA where there is a defect in this H plus ATPase. There is a defect in this H plus ATPase most commonly, sometimes a defect in this H plus K plus ATPase, because of which H plus ions are not being pumped into the lumen. So this is the lumen, this is the cell in under discussion, this is the alpha intercalated cell of the cortical collecting duct. So H plus is not coming into the urine, or you are not able to acidify the urine. So that is a basic problem. RTA type 2 is called proximal RTA, which is a generalized defect in the PCT. That's very important to understand. It is not one particular thing. It's a generalized defect in the PCT, due to which who is not reabsorbed? Bicarbonate is not reabsorbed. Okay, so this is much more severe. This is less severe, yeah, because there are other parts to compensate. So this is much more severe, this is less severe. That's again a base idea. In type 1 RTA means you'll be having like 0/5 power and hypokalemic paralysis and all that. This is less severe basically. Okay, so now let us try to write it up. RTA1 or RTA2 is the diagnosis here. Both of them are characterized by metabolic acidosis, correct? What type of metabolic acidosis? Normal anion gap metabolic acidosis. This is very important to understand. Normal anion gap metabolic acidosis means that anion gap in blood is sodium minus chloride plus bicarbonate. Whenever there is acidosis, you are having a loss in bicarb. So if chloride compensates, then the anion gap doesn't change. If somebody else compensates, the anion gap increases. Here it is going to be normal anion gap metabolic acidosis. So the compensation is going to be by chloride. So that's why if you look at chloride values are on the higher side, 108. More than 102, 103 is high. So definitely 108. Correct. So that much also you know. Now the most important part is, it's normal anion gap metabolic acidosis. Urine anion gap is also given as positive. Yes, urine anion gap is also given as positive. I have taught you how to look for urine anion gap positivity. Urine anion gap means urine sodium plus urine potassium minus urine chloride. Okay, minus urine chloride. This is urine anion gap. It is generally negative. Okay, generally slightly negative. it becomes positive only in one condition, that is RTA, positive only in RTA. That's what you need to know. Just remember that positive urine anion cap is RTA is more than enough, but just remember that total number of cations is equal to total number of anions. Measured cation plus unmeasured cations will be equal to measured anions plus unmeasured anions, total cations and total anions. Measured cation minus measured anion is equal to unmeasured anion minus unmeasured cation. Correct. Measured cation minus measured anion is equal to anion gap. So anion gap is equal to unmeasured anion minus unmeasured cation. So when unmeasured cation decreases, that is when urine anion gap becomes positive. So it's negative or positive. So when unmeasured cation decreases, anion gap becomes positive. So in RTA, because H plus is not coming into the lumen, NH3 cannot combine with H plus and form NH4 plus. That is the basic theory. So when NH4 plus is not formed, NH4 plus in urine is low because H plus is not there in the lumen. Unmeasured cation, NH4 plus is an unmeasured cation, it goes down. So anion gap increases. Okay, so that is the theory. You can again watch that. So the basic theory states that when urine anion gap is positive, there is only one diagnosis, RTA. So how will you write RTA? RTA is equal to hypokalemia with normal anion gap in blood, metabolic acidosis, with positive urine anion gap. So hypokalemia, normal anion gap, metabolic acidosis with positive urine anion gap. This is what is equal to RTA 1/2. Okay, so that's it. So if you go back to this question, you can also say normal anion gap metabolic acidosis will be associated with hypochloremia. So you can say hypochloremic normal anion gap metabolic acidosis with positive urine anion gap can be seen in RTA 1 or 2. So this case, when you read so much, you know that all these things are given. You are not in a position to pick up as to whether this patient has what, RTA 1 or RTA 2, because with this much data, I can only say that there is RTA. Yes, I can only say that there is RTA. Now, how will I know whether that is RTA 1 or 2? Now, hypocalcemia is given, correct? Urine pH is given. These are the other two things that have been given to me. Let me just try to tell you how to differentiate. We can look for fractional excretion of phosphorus or fractional excretion of bicarb, because both are handled in the proximal tubule. So if there's a proximal tubule defect, this will increase. If it is a distal RTA, then it will be normal, but these values have also not been given to us. Distal is a more serious concentrating defect because of this H plus ATPase, its importance. So urine pH in a distal RTA will be almost always more than 5.5. It will be 6, 6.5, 7. It will be generally in the range of 6 and above. Urine pH which is around 5.5 may suggest that it is type 2. But again, you can't say convincingly, because if it were type 1, it will be slightly more. Again, not sure. Then comes this very important clue, hypocalcemia. See, whenever you are having significant metabolic acidosis, as in type 1, what will happen is calcium will be released from the bone. So that will come into the blood and urine. So you'll be having hypercalcemia with hypercalciuria and stones. Hypercalcemia with hypercalciuria and stones. But in type 2, because the proximal tubule is what is reabsorbing everything, you will lose everything. So in that process, you'll be having more of hypocalcemia. So because of which type 1 has more of hypercalcemia, hypercalciuria, type 2 has got more hypocalcemia. That's a very tiny bit of information, but only if you know that, you can say that it is type 2. At your level, even if you say it is type 1 or 2, I think I'm happy. But the point is RTA 1/2. In this case, it is RTA 2, because of the simple reason that RTA 2 has hypocalcemia. RTA 1 has hypercalcemia, hypercalciuria. The reason for that is which has more significant acidosis, 1 is more severe, more acidosis, 2 is less severe. So that's the point. Okay, now let us try to see what are the causes. So when you look at RTA 2 is proximal RTA. This is slightly next level, okay, which probably as you work out more and more questions, you will come to see. Naturally, if it is next, you are having 120 questions means in medicine, surgery and OBG, 120 each means, then obviously you have to take your knowledge to the next level. And I'm so happy that in that process of taking your knowledge to the next level, you're going to be a much better, much more refined, much more professional doctor. So that I think is going to be working well for you. So we assume that this is proximal RTA. We think it is proximal RTA. Proximal RTA can be caused by drugs at this age. It is acquired. It's not inherited. 35 years, it is going to be acquired. Or can be due to certain rare causes for Fanconi syndrome, which you expect at this age. So Fanconi syndrome child means you think more in terms of stenosis and Low's disease and all those things. But here that's not working. Wilson can present in and around 20, so can present. Then myeloma can also present. So these are the other two causes. But again, in this particular case, both not fitting, 35 years not fitting, female not fitting, no other history. So drugs. When you come to drugs, the single most important drug is tenofovir, then ifosfamide, sometimes cisplatin, okay, but tenofovir, ifosfamide, then outdated tetracycline, okay, rare cases of aminoglycoside induced, but two classical drugs are tenofovir and ifosfamide, okay, this much you know. If it are RTA1, then mostly it is autoimmune, so you think of Sjogren syndrome, that's the most important cause, or distal RTA most often associated with Sjogren, and Sjogren with PBC, that is the classical association. Drug wise, most importantly, it is amphotericin B that you have to remember. So more drug is like for 2, 1 means less likely to be with drugs, and it's, if at all, it is amphotericin B. Here tenofovir, ifosfamide, cisplatin, outdated tetracycline, aminoglycosides, those things are there. With that, you go back to the question. Okay, now you know it is RTA 1 or 2. With hypocalcemia, you know that it is RTA 2. So RTA 2 with hypocalcemia. MRI is showing hyperintensities, correct? And altered mental status is there. Patient is on some kind of a drug therapy, correct? Previously on a combination drug therapy. Whether the patient is compliant now, you don't know. Okay, so that is it. This much if you understand, I'm fine. The next level understanding, even if you don't have, is perfectly okay. That will probably gather in due course. What the examiner wants here is that this patient was on HIV therapy. HIV therapy means tenofovir therapy. Tenofovir is part of our HIV regime, okay? HIV patient can have altered mental status, correct? HIV patient having altered mental status, most likely cause with hyperintensity is this progressive multifocal leukoencephalopathy, PMLE. PMLE is very common in HIV patients. So the reason for patient's admission now is a PMLE, and the drug related complication occurring in this case is RTA2, and the drug is tenofovir. So even if you don't know PMLE and all, you still can answer this question, but they have given you this clue to make you think more in terms of tenofovir. So they are giving you the drug. So even if you don't know 1 or 2, it's like only few drugs. Out of these drugs, which can you make as a part of a combination drug therapy? HIV, TB, etc. are the ones having combination drug therapy, of which tenofovir is the one that can be brought up here, and tenofovir has got this complication of RTA. Okay, so the level at which an MBBS student needs to be knowing, we can actually divide it that way. The other two things are optional. PMLE is there in HIV patient, and the MRI of that we can probably think is higher level. What is expected out of here is to diagnose confidently RTA, with hypocalcemia to say that it is RTA2, to know that RTA2 is drug induced, RTA2 drug induced to know that it is tenofovir, and tenofovir is part of the treatment of HIV. Okay, this is how clinical question goes, and you can take this question anywhere. Hypokalemia question you can frame, and you can actually take the question to any direction that you want. You can again make the difficulty level, I mean, as per your discretion. You can make it easy, you can make it tough, you can make it whichever way on. And this is the anion gap thing. So once again, to always keep those anion gap things very clear. High anion gap metabolic acidosis, you know, has got a list of causes. Normal anion gap metabolic acidosis is almost always RTA. You can have GI loss of bicarbonate also. These are the normal anion gap causes. Alongside with that, ureterosigmoidostomy. These are the causes. And high anion gap acidosis, you know, is ketoacidosis, which can be diabetic ketoacidosis, alcoholic ketoacidosis, starvation ketoacidosis, and uremia, starvation, methanol, ethylene glycol, and lactic acidosis. So these many things are there. This is the complete list. Okay, so don't have any confusion with this. Right now, if you're okay with hypokalemia evaluation coming to RTA, that itself is super. From RTA to go to the one or two levels up will take a little bit of time. But I think by then you are actually in perfect shape. So it's a progressive thing. So don't ever get bogged down by that. Slowly, you can lift yourself up. All this is applicable if you go to this next level paper. Suppose they cancel off next and they continue with NEET, you need not actually know at this level. The level at which we are teaching is more than enough. But if it comes to next, then this clinical backup, theory backup, which is right now there, on top of it, practicing out questions like this will definitely boost your confidence. So on that note, we'll just sign off with 2 RCPU SMLE questions with options. So till now we were not seeing questions with options. We're now going to see 2 questions with options. Okay, so 2 questions which I thought of just introducing to you. There are n number of questions to be discussed, but as and when the exam gets announced and as and when they give us an idea about what level of difficulty will be they setting the question, etc., then only we can discuss to that point. So right now it's just a sensitization thing to just get sensitized to these things and to use your MBBS to the fullest, because I always think of MBBS as a course wherein See, you may become a physician tomorrow, you may become a radiologist tomorrow. This is your last opportunity to study all the other subjects, barring that one single subject which you're going to pursue as your career. You just imagine, imagine that, and you'll understand the difference. That means today, whatever gynec I know, whatever surgery I know, whatever ENT I know, whatever ophthal I know, is dependent on the exposure that I got in these subjects as a MBBS student and as an intern. From that point in internship, I have never actually gone back and visited those subjects at any one single time. So which means whatever I know in gynecology right now is primarily the gynecology that I have learned during MBBS, the internship that I have done, the deliveries that we have taken, the CS that we have assisted, and of course the postings in the ward and in the labor room that we have had. So my knowledge or my skill has not been upgraded from that point. It is stuck up at that point. So the value of MBBS is how much ever good a college you get a PG seat, you're going to pursue only that one single subject over there. That means your opportunity as far as the other subjects is over. So people who are doing MBBS now, please understand the value of that and try to spend as much time in the wards, because nobody will question you right now. Nobody will ask you why you are staying there. Nobody will ask you why you are seeing patients. If you become a postgraduate in medicine, the moment you go to ENT and start seeing a patient, people will ask you, what happened? Why did you come here? Why are you here? If you say that I want to see this patient out of interest, they will laugh at you. So that means your opportunity is done, gone. You can't see those patients anymore unless and until those patients are related to you by some way, or your friends or your relatives or your neighbors or something. Otherwise, you can't. So basically, make use of this opportunity. MBBS is one beautiful course. I don't think there is any course in the world which can be compared to MBBS. That is primarily what I feel, because the wealth of experience that you get as a human being, because uh, people who have been brought up in trying circumstances, I've seen them actually say that I have studied without electricity in my house and all. I've actually heard my father say like that. So I used to laugh at it, because we were all, most of us, including me, you, we've been born and brought up in families where we've had actually plenty of things with us. We've never had these constraints, or what you call electricity constraints or food constraints, stress constraints, nothing like that. So going to MBBS for me was just a gradation. I mean, just from school going to the next course. But from a hi-fi polished school that I have studied in 12th standard to go to a core government medical college where the scenario is totally different. I think that's for the first time that I started getting in touch with what is reality. Till 12th standard, what I was doing was being part of a very poor school, going to school mostly by car, coming back sometimes by bus, and leading a very easy life. But from MBBS, I think that realization is something which was huge, was immense. So that is why I think this is a star course, a course which can change your life in so many ways. So let us see these two questions. So this is HVPG procedure. So this question is actually on HVPG procedure, which we have discussed. Okay. So HVPG procedure and its interpretation, readings have been given. You should be able to come up with the answer. So what is this HVPG? So previously we used to if somebody asks you, a patient is there, he's got cirrhosis, how long will he live? If somebody is asking you, then what can you answer? You say that I don't know. How can you say? But you can. It depends upon whether his cirrhosis is decompensated or not. So decompensated cirrhosis patients generally without a transplant won't survive for more than 3 years. But if it is not if it is compensated cirrhosis, means he may live for a long time. How do you know whether it is decompensated or not? Okay, that we will come to. But before that, the $1,000,000 question is whether he has portal hypertension. That is the single most important thing. Portal hypertension is there, then any decompensation can happen at any time. Ascites can happen, bleeding can happen, encephalopathy can happen. So it can happen that way. So the most important part is portal hypertension. And how do you know whether a patient has portal hypertension? Can you go and measure the portal vein pressure directly? No, you can't measure the portal vein pressure. So portal hypertension is equal to an increase in your sinusoidal pressure, correct? Because who is the culprit? Sinusoid is the culprit. Why do you get portal hypertension in cirrhosis? Defenestration of the sinusoid, nodules going and compressing the sinusoid. So it is sinusoidal pressure that is increasing in portal hypertension. So this sinusoidal pressure can be measured directly? No, we can't measure directly. So we have come out with a method to give an idea about the sinusoidal pressure that will tell you how risky it is for the patient, whether it will bleed or not, and accordingly to start beta blockers or even go for endoscopic variceal ligation, etc. like that. So that way we have found out this method called HVPG. What is HVPG equal to? Hepatic venous pressure gradient. That is equal to wedged hepatic venous pressure minus free hepatic venous pressure. So wedged hepatic venous pressure minus free hepatic venous pressure. So you introduce a catheter through the IJV, you traverse across the IJV, and then you come into the hepatic vein, and then you come into the junction between the hepatic vein and the sinusoid. At that point, that's the junction between the hepatic vein and the sinusoid, you inflate the balloon. The pressure that you get by inflating the balloon is the wedged hepatic venous pressure, wedge between the sinusoid and the hepatic vein. When you deflate the balloon, you get a normal hepatic venous pressure that is called free hepatic venous pressure. The difference between wedged hepatic venous pressure and free hepatic venous pressure is called your hepatic venous pressure gradient. This we have discussed in the videos on portal hypertension. So this is the theory that you have to be knowing, and they have shown you how this procedure is being done, and they have also given you results. So when the balloon has been inflated, you can see a pressure 22 millimeters, which they have shown is increased. When the balloon is deflated also, you can see a pressure 18, which is increased, and they have asked for what is the option. Okay, seems like a tough question, but actually not. It's a very, very easy question. If you know the theory, it's very simple. Wedged hepatic venous pressure minus free hepatic venous pressure is equal to HVPG. HVPG is reflective of the risk for bleeding. Okay, so that is how you have to interpret this. Portal hypertension can be due to pre-hepatic causes. It can be due to hepatic cause, that is your sinusoidal cause, and it can be due to post-hepatic cause. Post-hepatic cause means Budd-Chiari syndrome comes to mind. Pre-hepatic cause means EHPVO is the one that comes to mind. Others are also there, but most important. Pre-hepatic cause means your wedged hepatic venous pressure will be normal. Pre-hepatic venous pressure will also be normal. So both are going to be normal. Sinusoid means wedged hepatic venous pressure will be increased. Pre-hepatic venous pressure will be normal. Correct? So the gradient will be increased. In Budd-Chiari syndrome, which is post-hepatic, wedged hepatic venous pressure will be high because sinusoid is also involved. Pre-hepatic venous pressure, that is the hepatic vein, is also involved, so that's also high. So the gradient will be normal. This is how it is, and I've shown you the table also so many times. So when both are increased, then it is a post-hepatic cause, and the post-hepatic cause is Budd-Chiari syndrome. When only wedged hepatic venous pressure is increased, it is a sinusoidal cause, and the answer is any sinusoidal cause for portal hypertension. When both are normal, then it is a pre-hepatic cause. Pre-hepatic cause can be anything, of which classically what we study is EHPV, although it is seen in children, etc. Prototype example that we study is EHPVO. So you come back to this question, 22 increased, both are increased means post-sinusoidal is Budd-Chiari syndrome. Classical MRCP USMLE question, okay, where image is there, findings are there, lot of theory is there, application is also there, and balloon is also there. Okay, one more such question we'll try, and later on in the app we'll try doing so many such questions, and as you keep working up these questions time after time, your confidence level will increase. Let us see this question. 24-year-old male presented with polyuria polydipsia. I told you, whenever you hear the word polyuria, naturally what comes to your mind? Solute diuresis, water diuresis. Okay, water diuresis. Here diabetes etc. not mentioned, mannitol etc. not mentioned. So we take it as water diuresis. Water diuresis is equal to DI. DI can be central diabetes insipidus, peripheral diabetes insipidus, or psychogenic polydipsia, but psychogenic nothing is mentioned. So I take it as central or peripheral DI. Correct. They have gone for the water deprivation test. Serum osmolality slightly on the higher side. Okay, that doesn't mean anything. Okay. Urine osmolality is very, very low, which means we are having water diuresis. Urine osmolality after water deprivation is still very, very low, which means it is not any psychogenic or anything. Serum vasopressin after dehydration is undetectable, and change in osmolality with desmopressin is increased. So it's very easy. After giving desmopressin, it has increased, which means what are we dealing with? A problem where there is no desmopressin. So when there is no desmopressin, we call it as central diabetes insipidus. What is the cause for central diabetes insipidus? This is the hypothalamus. This is the pituitary, and they know that there is a stalk. Okay, from the pituitary, something going and hitting on the stalk. When it is hitting on the stalk, then vasopressin cannot come. So the reason for a central diabetes insipidus is always stalk effect. Stalk effect can be due to tumor, can be due to infiltration, whatever it is. Now the next image has been given. That is to look into the CT. Okay, on looking into the CT, you can see HRCT of this particular patient. You can see a small nodule. Yes, you can see small nodule. Cyst is not there. You can see just a small nodule, and two pathways which are activated in the same disease. That is one mTOR pathway and one BRAF pathway and RAS pathway. These are all activated in this disease. We don't know what it is. So nodule is there in CT, plus you are having central diabetes insipidus with polyuria. Okay, this much is enough to actually make a diagnosis. Let us see how many of you can. Pituitary adenoma, pituitary metastasis. Pituitary adenoma correct, pituitary metastasis correct. But why nodule on the CT? It doesn't fit. Sarcoidosis correct. Sarcoidosis can have nodule on the CT. Can, but not common. Amyloidosis does not involve the lung. Langerhans histiocytosis is LCH. Yes, Langerhans histiocytosis is that one very, very important condition where you can have nodules and cyst in the upper lobe. Nodules and cyst in the upper lobe. In sarcoidosis, it is more of infiltrates with bronchovascular thickening. Yes, bronchovascular thickening with infiltrates is what we see in sarcoidosis. Nodules and cyst in the lung. in the specific nodule we can actually see here with activation of the RAS pathway, mTOR pathway, which is linked to the central diabetes insipidus, always should make us think of Langerhans stenosis, because when you think of central DI, you know something is going and hitting on the stalk. This something hitting on the stalk is mostly a tumor, or it can be an infiltration. Tumor means pituitary adenoma or pituitary metastasis, something like that. Infiltration means we mostly think of sarcoid, we think of Langerhans histiocytosis, and rarely some infection also. So these are the two most likely things here, sarcoid and LCH, of which sarcoid means you would have seen infiltrates on the X-ray. You would have seen the scadding scoring, and you know, hilar adenopathy, infiltrate, then hilar adenopathy with infiltrate, then fibrosis. Nodules are not classical. Here, classical nodule is given mTOR pathway and MEK1 pathway, and BRAF is also given. And BRAF inhibitors called vemurafenib is now being used in this. That if you don't know is fine. That's not important for you. But this, if you link to the central diabetes insipidus, is very easy. Correct. So polyuria evaluation I have taught you. This is how you apply this polyuria evaluation. In that, you know that this is water diuresis because the urine osmolality is actually very low. Water diuresis can be due to central DI, nephrogenic DI, psychogenic polydipsia. Psychogenic, nothing is given. After vasopressin, osmolality is increasing, which means it is central DI. Central DI means vasopressin is not there. Not there means it is not like it is not being produced. It is something going and hitting on the stalk, and vasopressin is not coming. So that going and hitting on the stalk can be a tumor or an infiltration. Tumor is pituitary adenoma. Infiltration can be sarcoidosis or Langerhans histiocytosis. Here lung is involved, so it is naturally equal to Langerhans histiocytosis or sarcoidosis. Sarcoidosis lung involvement is hilar adenopathy and infiltrate. Nodule and cyst in the lung is Langerhans histiocytosis. So the most likely answer is Langerhans histiocytosis. So I don't know whether this is going above board for most of you, but this is the first step that we are taking in this direction, because I have myself discussed a lot of clinical stuff, but I have not discussed USMLE MRCP pattern so far in the app. So this is the first step that we're taking in that direction, thinking that next will be along those lines, and to just sensitize you to what is clinical medicine and get a feel of these clinical kind of question discussion. Although when we talk about one topic, right, if I'm teaching you say Langerhans histiocytosis or sarcoid, when we keep on talking about that, you will not feel this difficulty, because you're just keeping on talking about that, and you just keep on writing the notes, you follow the notes, you understand the topic, and you feel okay, fine. But the moment we make it a question like this and start discussing from here, there, etc., then it becomes very difficult. See, every question that we have discussed has basically only one theoretical point, but it has been framed that way. See, this question, what is the theoretical point? Langerhans histiocytosis produces central DI with nodules in the lung. What is the point here? Budd-Chiari syndrome produces increase in wedge hepatic venous pressure and pre-hepatic venous pressure. What is the point here? The point is tenofovir produces proximal artery. What is the point here? APML can present with DIC. What is the point here? SGLT2 inhibitors can produce euglycemic ketosis. What is the point here? Aortic stenosis can have angiodysplasia associated bleeding with syncope, angina, and dyspnea. What is the point here? Guillain-Barré syndrome can have axonal pattern of weakness with ascending paralysis with anti-GD1 antibody. Albuminocytological dissociation may not be seen, may be seen. If not seen, then you can think of HIV. What is the point here? Autoimmune hepatitis can have waxing and waning of jaundice. So everything has just that one or two points, but when you frame it as a question, then on the whole, it has to come to your system. But that comes through constant practice only. Okay, so don't take it that way. Slowly, you'll fall into the group. Everybody is talking clinical. So I also just thought of sensitizing you to what I feel is clinical. And anytime you can approach for anything that is relating to clinical medicine, because we are basically clinical people. Whether you shy away from this or not, the moment you have joined MBBS and passed MBBS and you have the degree with you, as long as you are alive, you are going to be getting these kind of questions. You can see people who have left MBBS and gone to other profession, even they say, like when they're working in some space, like for example, they're not doing anything relating to medicine. When somebody falls sick, automatically they will ask them. They may have left medicine years ago. You can see IS offices, you can actually listen to their interviews. They are now into a completely different stream. But even there, they are facing questions relating to medicine. So that is how medicine is. So once you are in medicine, then you're always in medicine. Fine. So hopefully discussion was of use, and hoping to see you with such discussions again in future. Thank you.